Dear moderator, respected panelists and learned audience, Assalamu alaikum. I am Dr. Matiur Rahman from United Hospital going to present my case. Title of my case is PCI in heavily calcified RCA, a battle of Hardwire. Brief about the history of my patient, Mr. HK, 72 years old, an orthopedic surgeon, presented to us with effort angina, class 2, CCS class 2 for last 6 months. He underwent CABG with 3 graft Lima to LED, RSBC to WEM and PDA in 2006. And Relux CAG was done in 2015, which revealed native triple vessel disease with only patent graft in Lima to LED. PCI to distal RCA was done at the same settings, and other 2 graft was occluded at that time. He is having risk factor, diabetes, hypertension, and ex-smoker. Echocardiography showing basal and mid-inferior wall hypokinetic, and ejection fraction 50%. Lab reports was normal, and resting ECG only in lateral ischemia. His coronary angiography revealed left main distally diseased and LED diffusely diseased, 99% calcified lesion from its proximal part, and CTO from mid segment, LCX totally occluded from proximal segment, and OM diffusely diseased. Right system revealed heavily calcified RCA, patent stain in the distal RCA, 40 to 50% lesion in the proximal PLV, and 95% lesion in the PDA. And Lima to LED graft was patent. So our diagnosis was native triple vessel disease with gap vessel disease with patent stent in the distal RCA. And recommendation is revascularization. What ESC guideline says in case of post-CABG patient? In repeat revascularization is indicated in patient with large area of ischemia or severe symptoms despite of medical therapy. If considered safe, PCI should be considered as a first choice over CABG. And PCI in the bypass native graft in the lowest circle, red circle you see, PCI of the bypass native artery should be considered over PCI of the bypass graft. And reduced CABG should be considered for the patient without patent EMA graft to the LED. So how to deal with this lesion? Balloon and where? Cutting balloon, open balloon, Rota ablation, or IVL. So our plan is PCI to RCA. First, we approach through right femoral, took 7 French chair, and wired with BMW easily crossed, and first tried with IVUS negotiation but failed. And took 2 into 15 NC balloon and pre-dilated. It is undilatable lesion. Body were taken and pre-dilated with 2.5 into 12 balloon, inflated at high pressure, but it was undilated. Again, try with crossing of IVUS but not crossed. We took smaller balloon, 2.5 into 8, and inflated at high pressure, but in vain to dilate the lesion. IVUS not crossing again. And we took cutting balloon, 3 into 10, with the help of Godzilla. You see, there is a dog bone effect. No significant plaque modification after cutting balloon inflation. So we took Rota, 1.5, and Rota run at 180 RPM. And you see the nice modification, plaque modification. And again pre-dilated with 2.5 into 15 balloon, and shorter balloon 2.58 balloon. And IVUS, after Rota ablation, you see there is arc of calcium, deep dense, and some area of cracked calcium by Rota. Resolute integrity stent 3 into 38 deployed in the mid and distal RCA, overlapping distal RCA previous stent, and 3 into 38 resolute integrity stent deployed in the proximal to mid segment, overlapping the second stent, and P-dilated with 3.15 and C balloon 3 into 10, and proximal part was post-dilated with 3.5 12 balloon. And final IVUS was showing well expanded stent, after post-dilation, the luminal diameter was satisfactory. You see 5.21 millimeter and 5.1 millimeter in the distal, 5.21 in the mid, and proximal segment 6.95. This is the final result. So take-home message: post-CABG patient with heavily calcified lesion. Lesion not a barrier for successful PCI. Appropriate planning, availability of hardware. Follow the stepwise technique. Deal with the heavy calcium. May overcome the obstacle. Suitable guide catheter, guide zilla extension catheter. Extensive support in negotiation of IVUS catheter. Crossing balloon and smooth delivery of the stent. Plan, patience, and perseverance is essential tools for successful intervention. Thank you all for patience hearing.